So Namaskaram, Suprabhat. Today we are going to discuss about episiotomy and its suturing. Ada, basically there are three things which I would like to discuss before we start this discussion of episiotomy. English, Hindi, Marathi combination चालेल ना? हाँ. So as we are aware, see, before starting this workshop, I would like to discuss about why we are doing it, where we are doing it, and how we are doing it. Medical colleges have a lot of infrastructure. Medical colleges have dedicated professional faculties. Medical colleges also have required equipments. But what lacks? There is equipment, there is infrastructure, there are skilled professionals. What lacks is the willingness to learn and the willingness to teach, going out of the box, going out of the way. And this I have observed since last 7-8 years as an undergraduate student in a government medical college and setup. Later to which I realized that trying to do it at our level by the means of different associations and organizations within the college itself, it limits our extent of work by this means. So we formed a NGO and we started a medical education department. What does medical education or medical service require? It requires skilled professionals and infrastructure. Now, infrastructure needs money, which we as an NGO are not capable of doing today. But at the same time, we are really capable and really willing and attempting in the direction to create skilled professionals. Skills are of two types. One is soft skills and second is hard skills. Before commencing this program, whatever we were discussing was a part of soft skill development, which talked about your backdrop, your background, the platform you stand at, the amenity that you have, the vicinity in which you are living now, studying now. And hard skills is whatever skill we can acquire as a clinician, one of which in the obstetric part is the episiotomy. As we know that it's a very, very basic obstetric but the most important obstetric procedure. I would like to begin with a small scenario. When I was an intern, we used to have our call from 8 to 8 a.m. in the morning to 8 p.m. in the evening, and 8 p.m. in the evening to 8 a.m. in the morning. So 8 p.m. 8 morning, it was a night call, and we were about to finish. It was about 6:37, 7:15 time, and a lady who was delivered and who was bleeding per vaginally was rushed into our labor room by some medical assistant from the periphery, and she was saying PPH, PPH, PPH. We know PPH is postpartum hemorrhage. The word partum means delivery, or it means active labor wala phase. Okay, partum is delivery. So before delivering of the baby is antepartum, after delivering of the baby is postpartum. So PPH, now it's a different chapter. We are not going to go in obstetric details of any terminology. We will understand them in brief as far as they are concerned with our workshop and topic, and we will try to touch them and understand our main topic, because all these terminologies are themselves individual chapters in the final year subject, and it is not practically possible to do it in a short time. So postpartum is after the birth of the child. Hemorrhage is bleeding, that is blood loss. Normally in a per vaginal labor you have a blood loss of about 350 to 500 ml of blood. In a C-section where you need a blood bag, it is roughly about 1 liters. When it is more than 1 liters or more than 1.5 liters, then you call it as PPH. There early phase, late phase, within 24 hours, within 12 hours, the classification is there. Now, so she came up with a complaint or presentation of PPH. The health personnel there said PPH. Then we tried to clean it with a mop, try to see where is the bleeding, what is exactly the cause, and we rushed her to the OT because she was a little febrile, the field was not clear, blood was oozing. In the OT they discovered that it was actually the unsutured episiotomy cut, which was taken in order to deliver the baby but not sutured properly, as a result of which the local bleed was so much which appeared as PPH. It was not due to atonic uterus or something like that. It was. So, moral of the story is episiotomy is a basic procedure which every medical graduate should know, because in the periphery there will be no one who will come and help us. So may it be from a government setup, may it be a person or doctor from a private setup, it is a must need that we should know this, because MCH care has a high rate of concern in our healthcare system and in our society. And as I was discussing, there is a lot of infrastructure, equipment, faculty there, but there is lack of willingness. But here there is willingness in the person who is teaching and in the person who is learning. And that is why we are sitting in a corridor on the benches without any projector, without any PPT, without any AC, and we are trying to learn something. So what drives is passion. What drives is curiosity. What drives is the need and the want to know. What drives is inquisition. And what drives is some aim, objective, vision and mission. And we are having it, and so we are doing it. Now, coming to the definition of episiotomy. We have labeled this workshop as SUSHRUT wannabes. SUSHRUT, as we know, is an age-old surgeon who has given us great, basic information about surgery in the SUSHRUT Samhita. And wannabes is want to be, because SUSHRUT operated at that time when there was resource scarcity, when science was not developed, when equipment was not such developed. At that time, during the British era, we had services like septoplasty of the nose, we had skin grafting, and we want to be SUSHRUT like, and so we have named it as SUSHRUT wannabes. Now, epi means around and tomy is to cut. So, to cut around is the simple basic definition, layman's understanding. And cut around what? So, exactly this definition answers all the WH questions. What is it? Episiotomy is a planned incision. So, what? It is a planned incision. Then second, where? It is on the perineum. Then third is when? During the second stage of labor. And then fourth is why? To increase the size of introitus in order to facilitate vaginal delivery. Now, let's understand this one by one. See, you might have learned in forensic medicine that there are different types of injuries. There is abrasion, there is laceration, and there is contusion, and many more. And each of the terminology has a defined classification. It has a different definition, at the same time it also has a varied classification. In that, laceration, when it is a planned incision, laceration is usually a blunt kind of hit with force perpendicular, and it is blunt force. So the surface which gets affected, it gets into a blunt trauma. It breaks up to flesh, it depends on the depth of the wound, but then it is ubad khabad, it is inappropriate, inapproximate, right? But at the same time, when it's a surgical wound, it's always a planned incision, okay, surgical. So it is a planned incision. Now why is it a planned incision? Basically, if you take a cloth and you make a nick and then you pull it in order to tear it, it will not break straight. The fibers were somewhere they will be long, somewhere they will be short, and the cut that has happened will be inapproximate. At the same time, if you take a scissor or a blade and cut it smoothly, then fibers will get cut into equal halves. So now if you suture them, which will be easy to suture? The planned incision one, the cut with the needle or the scissor or the blade. So easy to suture. Second, which will have more strength? Planned one, because it has a specific direction. It has a specific direction of cut, and it has a equally sufficient and method of stitching. So there will be more strength. And third, second time when you will try to tear it again, which will be easily and preferably torn, which line? That would be the again the planned one. जे वेडं वाकडं फाडलेलं आहे त्याला जर शिवलं ते शिवायला कठीण, त्याच्यानंतर त्याची स्ट्रेंथ कमी, आणि तिसरं म्हणजे तेव्हा ज्याला परत फाडायला लागता तेव्हा तो परत उबडखाबड होतो, जास्त उबडखाबड होतो, जास्त डिस्ट्रक्टिव्ह होतो. आणि त्या दिस सेम केस इज देअर विथ द स्किन अँड द मसल लेअर. सो इफ यू डोंट प्लॅन दिस इन्सिजन, the body will automatically create a tear or a laceration in the perineal muscles, as a result of which it will be difficult to heal, it will be difficult to suture, and when there is a subsequent labor and if there is an injury or a tear again, it will be more complicated. So what we do? Prevention is better than cure. So we make a planned incision. This is about what it is and explanation of the same. Now where? It is the perineum. Perineum is the area which involves the urethral opening, which involves the vaginal opening, and to some extent the anal opening. That area is the perineal area. We know that anatomy is all about landmarks and the names related to those landmarks. So perineum has perineal muscles, it has pelvic floor of muscles, and all these muscles insert at a place called as perineal body, which acts as an important support of the uterus. Okay. Now perineal area, as we are aware, okay, around the vagina we give a cut, a nick, which we will see in the subsequent slide. Now the third is when. This is a very important concern in episiotomy. It is when. When is second stage of labor. As we know that labor is divided into 4 stages. First stage, second stage, third stage, fourth stage. The first stage, it discusses about beginning of true labor pain to complete cervical dilatation. Now there is a difference between true labor pain and false labor pain. True labor pain, simple points to distinguish is when the pain starts from the back and it goes and inverts along the thigh. That is one of the characteristic feature of true labor pain. Second, no painkiller will be able to decrease that pain sensitivity. Third is they will increase in intensity, and these are all opposite in the terminology of false labor pains. So from the beginning of true labor pains to the complete dilatation of the cervix. Now how do we know? People who have attended clinics are aware that we do a per vaginal examination. We insert our 2 fingers, the index and the middle finger straight, and then rotate them with 90 degrees and then try to separate and measure the cervical length, cervical dilatation. Cervical length is different. Cervical dilatation. Now this complete extension of the index finger and complete flexion of the middle finger and the distance between these two fingers, this marks the full dilatation of the cervix, which is about 10 centimeters. If it is half, you say it is 5 centimeters. If it is just 2 fingers loose, you call it as 2 finger loose, that is 2 centimeter. Another important factor here is cervical effacement or softening or ripening, without which you cannot deliver. Otherwise there will be cervical tear. So you have drugs like rotavirin, etc., which help in the enhancement of effacement of the cervix. Once there is full dilatation, then it marks the end of the first stage. Second stage is full dilatation of cervix to the delivery of the baby. Now delivery of the baby itself is a 10-step procedure. Now we will see in the subsequent discussions what is malposition, what is malpresentation, what is the ideal position, what is the ideal presentation, and how the baby delivers in the namaskar position when it comes into the world in a normal vaginal delivery. So and then you remove first the head, then the anterior shoulder, posterior shoulder, the body and the legs, and the baby is out, and this is how you deliver. So once the baby is delivered, it marks the end of the second stage. The third stage, which is important from university point of view, the active management of the third stage of labor, which is a long question as well, and also significantly important in maternal and child care sector. So the third stage is from delivery of the baby to the more important delivery, that is of the placenta. And we usually deliver the placenta after giving oxytocin 10 cc in the IV drip, which is again diluted one, and 10 cc 20 cc depends, and we remove the placenta by modified Brand Andrew method. So I won't go into the details, but it is the modified Brand Andrew method, rotatory, and you push the uterus behind posteriorly and superiorly, and you rotatorily move your other hand. There is a specific position of holding the forceps, and you rotate and you pull it downwards and forwards, and you remove it by modified Brand Andrew method. Once the placenta is removed, it marks the completion of third stage of labor, and from that till the monitoring, which varies from patient to patient, which is normally between 2 to 6 hours, it marks the monitoring phase or the fourth stage of labor, where we monitor the vitals, because there is a lot of drastic physiological change. Okay, so now our discussion was second stage of labor. Now what is second stage of labor? Full dilatation of cervix to delivery of the baby. Now how do we understand when to deliver the baby? It is basically when the contractions are at its peak and when there is crowning which has happened. Do you know what is crowning? So basically when the baby descends, there is ischial spine which marks the zero station on per vaginal examination, below which it is +1, +2, +3. At the +3 station, you can see the head of the baby. When you push the head of the baby inside the uterus again, and if it goes, then it is not crowning. But when the head or the presenting part is visible, you are pushing it inside, but it is still not going. That is called as crowning of the head. And in that crowning, when there is contraction of the uterus, when you keep your other hand or palm on the uterus, you can feel the contraction of the uterus. And when you feel, and the patient will say it in normal layman's language, ki kal ali, because she can feel the reverberation of that pain, the vibration of that pain kind of. And she will say kal ali, and when you can feel the contraction of the peak when there is crowning, at the peak of the contraction we are expected to give the episiotomy cut. This is the most optimum time of doing episiotomy. Now the unwritten dictum of episiotomy is baby must deliver within 10 to 15 seconds of giving of episiotomy, probably less time. If it does not deliver it means our timing has mismatched. As a result of which there will be bleeding from the cut of the episiotomy wound, because the natural oxytocin and the pitocin that we give, the action of the pitocin over the uterus is it contracts the upper half and it relaxes the lower half, or the lower 1/3 part of the cervix and the uterus. When the uterus gets contracted, that the uterine vessels are between the muscle fibers which are arranged in a meshwork format. And what happens if this is the uterine artery or its branches, and if these are the muscles, when the upper part contracts, this contracts in a way that it closes the opening of the uterine artery and its branches, as a result of which pitocin and associated contraction decreases bleeding, which is the first line of management of PPH as well, of atonic bladder. So this contraction is of most significance, but at the same time the lower half is relaxing, where we have given a cut, as a result of which these artery mouths will be open and it will bleed. So it enhances your complications and challenges to deliver the baby in a bloody field of mismatched timing of episiotomy. The fourth thing is, why do we do it? To increase the size of introitus. Introitus is the opening of the vagina and the cervix, which in the layman's language is called as the birth canal. So the cervix is a kind of funnel where you have an external os and an internal os which mark the gates of the cervix. And why do we do it? Is to facilitate normal vaginal delivery, and is the most common operative procedure that is performed in obstetrics. Now, what are the indications? Whenever it comes to pregnancy, whenever it comes to labor, the only two important entities that are of concern to us, one is the mother, second is the child. So indications would also be maternal and fetal. What could be the maternal indications? See, we know that there are there happen immense amount of changes in terms of physiological alterations in the mother in the 9 months of her pregnancy. The only reason is that baby should deliver properly. All the alterations that are happening in the normalities of the physiological parameters, उनका केवल एक ही ध्येय है जिंदगी में बॉडी का, ये बच्चा अच्छे से पैदा होना चाहिए. So they try to lax the muscle mass, they try to strengthen it. But what happens despite all these, when it is for the first time, always there is a hesitation. Like we also, when we appear for the exam first time, even if we have prepared for the complete year, it is always a hesitation phase, it is always a resistant phase, it's always a anxious phase. And this is same with the perineal muscles, and they remain rigid. So in a primi gravida, basically you might be knowing the obstetric formula GPLA, where G is gravida, P is para, L is living, A is abortion. So gravida, it simply means conception, pregnancy. Whether the child or the abortus remains or not is a different story. Once she is having primary amenorrhea due to pregnancy or conception, it is gravida. Para is when it passes or crosses the age of viability, which is 28 weeks in India and 24 weeks in some developed Western nations. Third is living. L is how many are alive, and A is abortions. A challenging twist question is, what would be the obstetric formula of a lady who has got conceived for the first time and holds twins within her? So think over it, and maybe you can answer sometime later. So primi gravida with rigid perineum. So now I'll tell you my experience. When I was a final year student, I used to go to the labor room, and I waited for the on-call overnight, and there was no one in the labor room, no any staff, no any intern, no any resident, and one gravida 4 patient was getting delivered, and I was very much anxious. I had delivered babies before that, but then in the supervision of some senior faculty. Now this time there was no one, but I will tell you, the baby delivered on its own. I just had to catch. Moral of the story is, as the gravidity increases, the uterus becomes more laxed. It becomes more, loose, and so it is very easy. But sometimes there can be multigravida with rigid perineum, reasons unknown. Again, to conduct instrumental delivery. This practice has over time it has decreased to minimal extent, because unfortunately we are not getting good obstetricians. Today if you see a common practice, they immediately refer the patient for LSCS. No doubt they want to avoid complications, but at the same time we are a little under-trained. People do not practice instrumental delivery these days, and the problem is, this can be defined with a small analogical example. There is an egg with a chick. If you break the egg from outside, what will happen?
Chick will depends.
The chick will not gain and develop the strength in the wings to fly high in the sky. It will be fragile. The same thing, if you observe the babies delivered by C-section, they are often having physiological jaundice. They are often having some, infectious disease, as a result of which they are kept in neonatal ICU. When the child passes through the birth canal of the vagina, all the bacteria in that region get accumulated over the skin, where your immune work starts in the baby. If you talk philosophically, in the Indian philosophy they have mentioned that what amount of pain happens to the mother, more than that the child inside, the fetus inside bears. And also it bears during the time of delivery. There is overriding of bones, there is sudden compression and decompression, and that is why it strengthens, this process strengthens the baby in all terms, physical, immune, etc., which is not at all seen in C-section. So C-section should be only conducted if indicated. Indication should not be created just in order to see C-section, and there is a big amount of craze these days we see in residents, where they want to have a lot of cut in C-section, because they know bahar jaake yahi karna hai. And even the mothers who bear children, because of a lot of pain in this process, they prefer for painless delivery, that is by giving epidural anesthesia or by straight away for going for C-section, which is not appropriate from health point of view for the mother as well as the child. As male faculty, we have no right to talk about this, because we are not going to feel that pain. But at the same time, if we want a good generation, there cannot be gains without pains. So considering all these factors, when we talk about instrumental delivery, we can recall the famous movie of 3 Idiots. So to conduct instrumental delivery, we need space to put forceps, vacuum, the ventouse forceps, etc. So for that, episiotomy is indicated. Now fourth thing is fetal malposition or malpresentation. We know that if we consider the pelvic brim or the pelvic inlet, then that shape varies in different females, gynecoid, android, etc. And in that we usually divide that oval shape into 8 parts, and as you know, there is 1/8 rotation, 2/8 rotation, etc. The normal position of, now there are terminologies, one is lie, second is position, third is presentation, fourth is presenting part. When we talk about lie, Lie means the alignment of the baby, longitudinal axis of the baby, longitudinal axis of the baby in association with the longitudinal axis of the mother. If the baby is lying parallel to the mother longitudinal axis, then it is longitudinal lie. If it is perpendicular, it is transverse lie, and if it is oblique between these two, it is oblique lie. Commonly the lie is longitudinal. Now second is position. Position is the relative position of the baby with respect to the pelvis of the mother. Now what is the landmark? It is the occiput. As you know that the pelvis can be divided into anterior half and the posterior half of the mother. Now occiput facing the direction of the pelvis marks the name of the position. For example, transverse lie, the occiput is on the left side of the pelvis of the mother and the baby is facing towards the right side and it is oblique in position. So left oblique occiput becomes the position of the baby, or left transverse occiput becomes the position of the baby. Now left oblique occiput, where the occiput is in the anterior half in the oblique direction, is the commonest position, where the baby rotates 2/8 of its neck, delivers in namaskar position, again rotates back and then gives anterior shoulder, posterior shoulder, and likewise. So they are the so left oblique occiput or left transverse occiput, this is the commonest position. Any other position than this is called as malposition. The most difficult is where the occiput faces the sacrum of the mother and baby is seeing towards the sky. Now the third terminology is presentation. First is lie, second is position, third is presentation. Presentation is which part of the baby is there pervaginally in the vagina. It could be the occiput, it could be the face, it could be the brow, it could be the back, it could be the limb, it could be the foot, which we call as breech. So normally it is what is the presentation? It is the vertex presentation. Okay, vertex, tuple position. So presentation, and the presenting part is the vertex, occiput. So that any other presentation, then this is called as the malpresentation. So now there are different maneuvers to rotate the baby to get it into the normal position and presentation. For those you need what? Space, and so you give a episiotomy. For an instance, occipito-posterior position, as I mentioned, which is the most difficult. Occiput lies on the posterior, that is on the sacrum. Face is seeing upper, or face presentation or beach presentation, to minimize trauma to the perineal. When we are manipulating, there are high chances that we may damage or tear the muscle. So to facilitate that, we give episiotomy. And last but not the least is previous history of complete perineal tear, that is third degree tear. The classification is ahead, we will see. So in that case, you must not take risk. If it is the previous history, see the episiotomy. Fetal indications. What are fetal indications? Delivery of preterm fetus. Preterm fetus में उसको बहुत जल्दी रहती है आने की. We have seen such cases in our labor room where the patient, a preterm patient, which we usually do not allow, but sometimes patient does not listen. Patient goes for washroom and brings the baby in the hand, delivered all by themselves, or delivered in the veranda, in the lobby. So baby wants to deliver quickly. In that case, there are 2 points. One is injury due to collision with the ground, and second is there is abrupt decompression and compression. पट से बाहर निकलता है विदाउट फुल इफेसमेंट, विदाउट ऑल दैट, खटक से ऐसा बेबी बाहर निकलता है. तो ओवर राइडिंग ऑफ बोन्स हैपन वेरी क्विकली ऑफ द स्कल, एंड एट द सेम टाइम दोज ब्लड वेसल्स they also abruptly get compressed and decompressed, where there is a high chance of their breach, and that may lead to bleeding, fetal hemorrhage. So intracranial hemorrhage, ICH, would be another cause. So in this case we give episiotomy. What are the advantages? As discussed in indications, it decreases perineal laceration and the chances of complete perineal tear, that is third degree tear, and easy, see, as we discussed, it's a planned incision and so it is easy to repair and it also heals quickly. Then it cuts the second stage of labor, right? Once we know that the baby is going to come out, there is crowning. Why wait for the crowning to happen completely? Better you give a swipe and you give a episiotomy. And third is provide space for application of the instrumental delivery, and it also minimizes trauma to pelvic floor. As a result, if pelvic body or the perineal body is strengthened, other supports of uterus are strengthened, then there is decreased chance or there is prevention of genital prolapse and urinary incontinence. And fetal advantages, trauma to preterm fetal head, and that is decreased, and it provides space for manipulation of the delivery of the baby. We can also recall a movie Robot of where there you can see manipulation of the baby. They don't go for C-section. There the case was the child gets entangled within its own umbilical cord. So this is about the advantages. The next important thing is the procedure of episiotomy, and before that, what are the different dimensions or the lanes where you can take episiotomy, suturing, cut. Now as you can see that this is the normal lithotomy position, where the feet of the patient mother are flexed at the knee joint, partially flexed at the hip joint, and she is delivering. Now this crowning has happened, we are pushing but it is not going inside. Now what will happen? After this there are three positions possible. Now this is called as the lateral position, this is called as the medial position, and this is called as the mediolateral position. Every position has its own advantages and disadvantages. After ruling out of them, we will come to the best possible, which is commonly practiced. So what happened? See, muscles are getting inserted or attached here at the perineal body between the anal canal and the vaginal opening. Now what will happen is blood supply will be more in the muscle part as compared to the tendon part. So bleeding here in the medial position, in the median position, would be less. At the same time, you will also get perfect apposition of the muscles for healing. असे सगळे मसल आहेत त्यांना सरळ कट केलं तो easy healing हो जाएगा, repair will be good. But what is the danger sign? That if it extends, it will directly form a fistula with the rectum, and that is not at all acceptable because it's a big complication. It will lead to anal incontinence and further complications. So we try to avoid median despite its advantages of less bleeding and proper apposition. Now second is the lateral incision. There is no limit, there is no fear of any fistula or any other complication of extension of the incision, but the problem is that there is high blood loss because that's the bulk of the muscle there. Second thing is poor healing because fibers will get cut in a cross position, so healing would be difficult. So and there is a high chance that there can be injury to the Bartholin glands and the duct present in the व्हल्व्युलार रिजन. सो याच्यात मध्यस्थी करणारा कोण, तर मिडिओलॅटरल. मिडिओलॅटरल काय म्हणतो, ठीक आहे मी थोडा ब्लीड करेन, मी थोडं हील करायला त्रास करेन, पण आणि मला एक्सटेंड पण तुम्ही किती पण करू शकता. सो इन्सिशन कॅन बी एक्सटेंडेड टू वॉट एव्हर एक्सटेंड. ब्लड लॉस इज ठीक and discomfort is also less as compared to median cut that is taken. Now how, so 5 o'clock position is the most appropriate and acceptable position. Instrument kit there. Now the thing is, how do we do this? Okay, how do we do this? Nahi. पाणीच्या बाटल्या ठेवल्या याच्यावर गदड्या, तू ते दुसरं वाला पण काढ. अरे यार मी एपिसिओटोमीची सीझर आणायचं विसरलो, जाऊ दे. तुला माहिती आहे एपिसिओटोमीची सीझर कशी असते? नाही ठीक आहे, एकच पण अवघड झाला. सो दिस इज अ फोम शीट, एटलॉन शीट दॅट वी हॅव in order to understand how we take a cut in the 3 dimension. Consider that this is the vaginal wall. So this is the skin, this is the mucosa, and this is the muscle. Now we take a episiotomy cut. Suppose if you are a righty, you will stand on the right of the patient. Patient is facing upwards this way and lithotomy position this way. You are on the other side. So this is the vaginal wall. So I will create, first I have already created space. Then I put my fingers to anchor the scissor and then I give a cut. Now episiotomy scissor, as we know that it is a little bent, it is a little tilted, and I always tell all students in fun and also a little seriously that this is the instrument which will be the savior of yours in the OBGY exam, practical viva exam of ops in the instrument section. Why? Because it's most easy to identify, and once you identify and if the examiner goes for the viva on this, you will explain all episiotomy and they will you will be on the safe side. Now how do you do it? Now that angle which is tilted is kept on the outside. 2 reasons. One is the head of the baby is convex and the inner wall of the vagina is concave. So you don't want to injure this convex part, so you will keep the tilt on the outer side. Okay. Second is that matches the angle of the concavity, and because of these 2 reasons you will keep the scissors like this. You create space, hold this, you create space and this is your angle and you put the scissor and you cut. Now this is a type of injury to the baby, to the mother, right? It's an incision but it's an injury. And so at the same time the injury, the pain of the injury can be felt. The pain of the injury can be felt only in the layer of the skin. The muscle is not having any pain receptors. The skin and the subcutaneous tissue only they have pain receptors. So you take a lignocaine injection of 5 cc and you give it in a subcute fashion. Now subcute fashion is that plane in which you are going to take the incision. You prick the complete needle, try to pull it outside to check whether it has not got into any blood vessel, because there are, what are the pharmac question, complications of local anesthesia delivered in the vein directly. So this is homework. Okay, what are the complications? So always you must check, and if the blood is not coming out, coming inside the syringe, it means you are safe. Then there is push and pull phenomenon, means you are pushing the drug and pulling the needle, pushing the drug, pulling the needle, so that this drug is there in the complete plane where you want to take the episiotomy cut. Once this is done, you take an episiotomy cut. I will tell you, in government setups, due to such a lot of wear and tear and such a high amount of turnover of babies, they are always blunt and it is very painful when it happens. So you do this and you take an episiotomy cut. Once the cut is taken, baby is delivered, placenta is delivered, all clots to be removed. Now as we saw that there are 3 layers. One is the skin, second is the muscle, and third is the vaginal mucosa. How do you suture? First you take the apex of the mucosa. Now why it is significant to identify the, I have a few photographs which I will show you after this briefing. This apex, if not taken properly, it is high chance that it will get extended upper and the bleeding will continue, and that will lead to lot of complications. So what should be done? Clean the area with the mop. The field must be clear. It will be bloody, but it must be clear for you to identify the apex. And 1 to 2 fingers above the apex is the point where you take the first suture. Once you take the first suture, there are 3 types of sutures: continuous interlocking, second is intermittent, and third is matrices, horizontal matrices, that we are concerned here. So here you take the first suture 1 or 2 fingers above the apex, give it a knot in 2-1-1 fashion, and then take again continuous interlocking sutures. I will demonstrate to you how it is to be done. Continuous interlocking once done, you come to the mucocutaneous junction. Once you reach the mucocutaneous junction, then there is feeling of pain in the patient. At that time you can either counsel kaku ekach hai, tai ekach hai, because that prick is not going to create lot of difference. But if you feel, you can give a local anesthesia there in that suture. In residency you don't have so much of time, so at mucocutaneous junction little bit there will be there pain, and then you close this suture again by 2-1-1 and cut it. Then once it is done, then so apex has been taken here. Can you see this? Vaginal mucosa, apex has been taken. Second is completion of the mucosal suturing. Then third is completion of the muscle, this brown part, muscle. How do we suture the muscle? In any kind of surgery, muscles are only to be approximated, only to be apposed. They are never sutured like the skin or the fascia, like the skin or the mucosa. They are apposed, they are brought together, and you do it by simple suture, 1 or 2. If the depth is more, if the patient is obese, muscle fat thickness is more, then you take it in 2 levels, 1 deep, 2-1-1, again 2-1-1. Why do we do it? Because we want to suture the skin. Muscle when brought near, it eases and decreases the tensity of the suture over the skin. म्हणजे ह्याला सुचर करायचं आहे, यांना जर जवळ आणलं तर हे इझी पडेल. आलं लक्षात? हे जर असं असेल आणि यांना ओढून आणायचं असेल तर ह्यांना जास्त ताण या टाक्यांवर पडेल. सो वी ब्रिंग द मसल टुगेदर, अप्रोप्रिएशन. अँड वन्स द मसल लाईन इज सुचर्ड, देन यू सुचर द outside the skin, that is through matrix. Now there are 2 approaches again. One is from the from the posterior to anterior, and some do anterior to posterior. Anterior to posterior, they give the reason that blood loss get controlled, but there is high chances that your approximation goes wrong. मग नंतर स्किनचं गोल राहते शेवटी खाली. That is very bad and very bad for healing, cosmetically also and healing also. So we approach from posterior to anterior, and we take 2-1-1 matrix. I will tell you far near, far near, and we complete till the mucocutaneous junction on the cutaneous side. This is how we complete the suturing. Now what happens is, you are suturing, there is intense continuous bleeding. How do you understand whether this bleeding is from the uterus or whether this bleeding is from the episiotomy cut? So there is a concept of mopping, there is a concept of pressure necrosis. You apply the mop, it will soak the blood, you see whether the blood is oozing. If it is oozing, it means it is from there only. So you quickly suture. If you put it, if it is not oozing from here, coming from above, then it means bleeding is happening from the uterus. So again you must revisit the uterus per vaginally, remove all the clots. If it is still bleeding, it will take time to get clot, it will take time to contract. It becomes stony hard, like 12 weeks, 18 weeks ka uterus. You can feel that it really becomes stony hard. So you can feel it per abdominally. Now here what you do, you take a mop, you put it in the mouth of the cervix, and it soaks all the blood from the above, and then you suture here, and after you are done, you remove the mop. Many a times in a lot of hurry, our residents forget to remove the mop, and blood, and even if you don't remove the clots, blood, you have learnt in microbiology, blood agar is the source of growth, the place of growth. It gives all nutrients, blood agar. So if there are blood clots, or if there is anything like this, the mesh or the mop with blood inside, it will lead to lot of infections, and that will lead to purpural sepsis, and that's a great complication, and that's a great negligence professional, and it will lead to lot of problem to the patient as well as to the doctor. So always check for the mop, and once suturing is completed, always check the suture line whether it is patent, intact, by simply palpating over it. Do not stretch it and see, because it will tear. Sometimes the few patients' skin is very fragile, and while taking suture it tears off. At that time you have to take the suture from a little proximally of the tear and complete it. So this is how we do about the episiotomy suturing. A few complications, early and late. What could be the early or immediate complications is local bleeding. It means what, हमने suturing ठीक से नहीं किया है. Second is vulval hematoma. Local anesthesia when given, it also acts like hemostatic agent. If it is given with adrenaline, best use. Vulval hematoma means what? That there is injury to the vulval area. The suture line is intact and correct, but that blood gets collected in the vulval region, leading to vulval hematoma. Hematoma is abnormal collection of blood. Then third is infection. As you know that our environment is highly aseptic when talking in terms of Vyang. So there are high chances that there may be infection. And wound gaping, if the clinician is not good at suturing, then there will be wound gaping. Now delayed complication, if there is inappropriate appropriation, then there are high chances of painful scar. As we have learnt in the pathology chapter of wound healing and repair, wound healing starts from periphery to center, that is in a centripetal manner, and it starts from equal distances. What will happen if one suture is taken here, another is taken here? If one is taken here, another is taken here, and on the other side this is a little far. So appropriation will complete here quickly, but here it will not, which will shift the healing line, this line, as a result of which there will be painful scar, and there also will be dyspareunia. Dyspareunia is painful intercourse due to secondary to this inappropriate healing. So there may be chance they go for intercourse after delivery, so that will lead to dyspareunia. Bartholin cyst and duct, as we saw, there are high chances of injury while taking a suture. It may be possible that we prick the duct or the cyst. And last but not the least is scar endometriosis. Endometriosis itself is an independent chapter in gynecology, but if I want to explain it in one line, is endometrium is a proliferative tissue, growing tissue, आणि endometrial lining सोडून endometrium कुठेही ग्रो व्हायला लागला, आपण मदत करायला जातो तसं ते म्हणते मी हील करायला येतो, तुझं होत नाही ना, मी येतो. ते चांगलं करायला जाते पण ते एंडोमेट्रियोसिस करून बसते. स्कारच्या ठिकाणी झालं तर स्कार एंडोमेट्रियोसिस असं म्हणतो. Perineal laceration that we were talking, complete perineal tear. So there are 4 degrees of perineal laceration. One is which involves the skin and vaginal mucosa only, which is called as the chota EP. Chota EP, just you give a nick and the baby delivers. Chota EP. Second is second degree tear, which is the normal episiotomy, which involves the skin, the mucosa as well as the muscle. Third degree is where it involves the anal sphincter. म्हणजे depth of this muscle it goes below. Skin गेलं, vaginaचा mucosa तर गेला, and the third thing is the muscle depth. Now that muscle depth extend to the anal sphincter. Now as you know, anal canal is also funnel like, so tubular cylindrical. It has internal sphincter near it, external sphincter outside it. So first कोण येणार, शिकार कोण होणार, external sphincter. So 50% and less thickness of external sphincter is 3A degree. More than 50% external sphincter is 3B degree. And internal sphincter involvement is 3C degree. And this involvement of anal sphincter to any extent is called as complete perineal tear, that is CPT. And fourth degree is it also extends till the rectal mucosa, which forms a fistula between the rectum and the vagina. This is a very complicated thing. Now how to repair? ज्या डायरेक्शन मध्ये डेप्थ वाढली त्याच डायरेक्शन मध्ये ऑपोजिट डायरेक्शन मध्ये हील केलं पाहिजे. सो फर्स्ट यू हील और रिपेयर द रेक्टल म्युकोजा, then you do the apposition of internal sphincter, then external sphincter, then perineal muscles, and then vaginal mucosa, and then at the last you do it with the skin. So this is the basic direction and step of repair of the perineal tear. As you see, for example, a patient of HIV, and if he has a co-infection of TB, so you first start treatment of TB. Even if the patient is HIV, if it's not competent, not compliant to medicine, you stop treatment of HIV time being. First you treat TB. In the same way, you first repair the rectal mucosa, anal sphincter, and then you go towards the episiotomy. So this is all about what episiotomy is, why it is done, how it is done, when it is done, what are the complications, what are the indications, and how we suture it. Now let us see the demonstration. Forceps is to hold. It may hold anything. Now based on what it is holding, the names have been given. For example, needle holding forceps. It means what? It will hold needle. There is artery holding forceps. It means it is used to hold the artery during operation, surgery. So how do we identify? Needle holding forceps is also very easy to identify. Any forceps has 3 locks, 1, 2, 3. These are the same grade stainless steel Germany made instrument that we use in the original OT. No compromise. Okay. Easy to understand is there are serrations crisscross. This is to give a proper anchoring to the needle so that it does not flip. Now even these serrations have a particular direction. So if for example this needle gets into one channel of the serration, again there are chances that it may get slipped. So that is why there is a khacha, a ratchet inside. This discontinuation in the surface with serrations leads to proper anchoring of the needle. And so this is also easy, it gives a hint to identify that this is needle holding forceps. No other instrument has such a kind of arrangement. Now these are 3 locks. They can be remembered as catch, clamp, crush. Catch, clamp, crush means what? To hold anything, for example this needle, you catch. Suppose this is an artery forceps, you want to clamp means what? Occlude. Then you do 2 lock. And if you want to, if it's a bleeder, you want to crush it to do pressure necrosis and hemostasis, you crush it. Catch, clamp, crush, CCC. So what we do, we hold that part and we do it 3-4 times. So there is pressure hemostasis there. Okay, are you getting? Now how to hold? There is a method for everything. This is the proximal end of the needle holding forceps. This is the distal. On the same side, on the other side, this is the distal pointed end of the needle, and this is the proximal end because it has a thread. Now the thread that we use in episiotomy, it is called as the catgut. Now types of sutures you will learn in surgery. There are 2-3 types of suturing materials. One is non-degradable, second is degradable, that is organic, and third is intermittent, which degrade lately. Okay, Vicryl and all these are non-degradable, inorganic, and organic is catgut. But it's a misnomer. It is not made from the gut of the cat. It is made up from the gut of the sheep, and it degrades in 7 days, 8 days, 1 week or so. So you don't need to call the patient. Now how to hold this? This is needle should be held at the proximal 1/3, whereas in the needle holder it should be held at the distal 1/3. Reason, if you hold it on the proximal side, you will have to insert the complete instrument and it will be difficult. So you place it in the distal 1/3 of the needle holding portion. On the contrary, if you hold it on the distal 1/3 of the needle, there will be no place to suture it ahead. So you hold it at the distal 1/3 of the needle and proximal 1/3 of the needle holding forceps. Then you catch it. And how to take. Now this is a tooth forceps. Can you see the tooth? There are 3 types of forceps: plain, tooth, and crocodile forceps, or where there are multiple tooth, 2, 3 like this. So this is to anchor the skin and the tissue. Now if this is the apex, one finger upper, one finger or 2 finger upper, so you take a suture here. So this basically is for the movement of our hands. To get a practice of this, how do you do it is you suture, you put it here. As we learned, healing happens from the in the equal opposite direction. So जितना दूर इधर prick किया है, उतना ही दूर इधर भी prick करना है, क्योंकि this prick itself is also an injury to the patient. So this approximately should come out here. You leave it, again you hold it here, and you little bit push it. It's out, coming out. Yes, it's coming out. Equal distance, almost equal. You leave it. If now what students do in practice, they hold it, ऐसा दबाते हैं, तो ये चिर जाता है और ये पीछे का टूट जाता है. So you close it, even in the skin of the patient. What you do, you push it a little. It comes outside. Apply opposite pressure here. Hold this, catch, and then remove this. This should be curvilinear. If you pull it straight, it will tear. Even the skin tears. Okay. Now, how to tie this? What I was telling you about 2-1-1 is this is the end of the thread to be brought here. Now this forceps is to be held like this, and this hand should not move. Only the other hand should move. 1, 2. These are the 2 loops. Hold this end of the thread in the right hand. Again, keep this stable. Just move this part. Sometimes it gets stuck up here. Just hold this like this in the opposite end, inside. Just this is sufficient. See, this hand is here only. Students, what do? ये दोनों को ऐसा खींचते हैं, ये वेस्ट हो जाता है. So it's of no use. You have to hold it here like this. Keep this stable. Right hand should be stable. Okay. Once this 2 knot is done, 2 tie has been taken, 2, then 1. Again वो निकल जाएगा ऐसा करेंगे तो. 1 second. If it's loose, this is also what happens many a times. So simply, when you are taking a suture, you have to be very careful. Even it may happen in the patients. So how do we do is just hold this, remove this like this. Okay. Then 2, hold this, keep this stable, right? Then 1, hold this here, and again 1. So this hand should be stable. This, okay? Because the thread is thinner,